So let's see about the incontinences. So the three most important incontinence is the stress incontinence, urge incontinence and the overflow incontinence. So what happens in stress incontinence and why does this happen? In stress incontinence, the common presentation will be when they cough, when they laugh, when they strain, then there will be an incontinence. So the laughing, coughing and straining is known as is the stress incontinence. So why does this happen? This happens when the pelvic floor muscles has become weak. So this can happen because of many reasons, but multiparity is the most common reason. What is the treatment for this? Kegel exercise is the treatment for it because it strengthens the pelvic floor muscles, the pubococcygis. If they ask you which sphincter does it strengthen, does it strengthen the external sphincter or the internal sphincter? The external urethral sphincter and the external anal sphincter is strengthened by the Kegel exercise, but the internal urethral sphincter cannot be strengthened because it is not under voluntary control and that is under sympathetic control. Now, what are the terms that can be associated with the stress incontinence? Since in stress incontinence, we have the urinary bladder as well as the urethra. So, this is the vesico-urethral angle. So, the main problem is because the muscles over here are weak, the vesico-urethral angle is disrupted. So they can tell you like there is a downward mobility of the vesico-urethral angle, or else they can tell you that there is atrophy of the urethral fat and there is impairment of the vesico-urethral angle, or thirdly they can even tell you like there is urethral hypermobility indicating that the angle is not proper. So these terms can be associated with stress incontinence. What about the urge incontinence? When does the urge incontinence happen and why does this happen? The urge incontinence will happen when there is detrusor hyperactivity. So the detrusor muscle is supposed to be in a normal state or else in a balanced state. That is, it should not be contracting always and it should not be relaxing always. But if it is in a contractile state, then that results in detrusor urge incontinence. Detrusor hypercontractility happens in urge incontinence. So when does this happen? This happens in multiple sclerosis patient. Why? This is because in multiple sclerosis, the cortical nerves which supply the detrusor muscle, so they are the inhibitory nerves. So those inhibitory nerves are affected in multiple sclerosis. So now we don't have any cortical nerves to inhibit the detrusor hypercontractility. Therefore, the detrusor is in a hypercontractile state because we don't have nerves to inhibit it. Therefore, this multiple sclerosis commonly presents with urge incontinence. How will the presentation be? The presentation will be like the patient might tell you when they get out of the car, they feel that urgency to pass urine. When they had stuck the key in the doorknob, they feel that urgency to pass urine. So all these can be the presentation. But you might be wondering, even in UTI they have this urgency. So how do you differentiate whether it is really incontinence or it is urinary tract infection? In urinary tract infection, this urgency will be associated with dysuria, but in other incontinence, the dysuria will not be present. What is the treatment for urge incontinence? The treatment is oxybutynin. So before we go further and know what group of drug oxybutynin belongs to, you should know about the sympathetic and the parasympathetic supply. The main action of the parasympathetic is to cause urinary flow, but the action of the sympathetic is to stop urinary flow. So the parasympathetic supplies the bladder and it causes the bladder contraction, but whereas the sympathetic will supply the internal urethral sphincter and it will cause sphincter contraction so that the urine flow is stopped. So now we want to stop the urinary incontinence. So for that we need to give parasympathetic antagonist. What is a parasympathetic antagonist? That is the muscarinic antagonist, which is M3 antagonist or oxybutynin. If this is too much, I have a simple clue which I used to remember when I was studying. So in oxy but in, you can just split the words so that it ends in. So therefore the urine is kept inside, and then you can think that the parasympathetic is the one which causes the urinary outflow. So therefore it has to be parasympathetic antagonist, that is M3 antagonist. The next one is about the overflow incontinence. As the name says, we have the this is the bladder, we have the urethra over here, and this is the ureter. So when there is an obstruction over here at this part, then this can result in overflow of the bladder and resulting in overflow incontinence. So why would we have an obstruction here? This obstruction can be due to benign prostatic hypertrophy or BPH. Sometimes this is one important cause for overflow incontinence. The second important cause can be diabetes mellitus. In diabetes mellitus, there is a neurogenic bladder. That is, the bladder is not able to contract because the nerves which are supplying the bladder is not proper. It has been affected by the diabetes mellitus. Therefore, it is in a hypocontractile state, just opposite to this. It is not contracting, it is in a hypolethargic state. Therefore, it is not contracting and letting out the urine through the urethra, and this results in an overflow incontinence. So BPH and diabetes mellitus are reasons for overflow incontinence. Now, when the patient is presenting with this, that is, they are having an incontinence, what should we do first? So we can do two important steps. Either we can insert a catheter and relieve the obstruction, which is a good one, or else if we really want to diagnose it, we can do a post-voidal residual urine test. Normally, after voiding, the urine should be approximately 50 ml in the bladder. So this is the post-voidal urine. But if the urine is 300 to 400, even after voiding, if there is 300 to 400 ml of urine in the bladder, that means there is increased post-voidal urine. So the next best step can be either of the two. So either you need to insert the catheter and relieve the obstruction, or check for the post-voidal urine, which should be more than 300, because the normal is 50 ml. Let's see what is the treatment for overflow incontinence. The treatment over here, now if you see, the bladder is not contracting, so we have to make it contract. Therefore the treatment is bethanicol. Bethanicol is the treatment for overflow incontinence. What will it be? It is a muscarinic agonist, because this is a parasympathetic supply, muscarinic, so that we are increasing the parasympathetic supply for it to contract. What happens in spinal trauma, spinal metastasis, as well as cauda equina syndrome? When this spinal trauma happens in the sacral region, or when the spinal metastasis happens in the sacral region, and cauda equina is obviously in the cauda equina. In all these three, the one which is common in all these three is that the sacral outflow, which is the parasympathetic outflow, is disrupted. Because of the outflow being disrupted, the detrusor is not supplied with the parasympathetic, therefore it can result in overflow incontinence. Get it? So how will this knowledge be tested? They can give you, like, a patient has cancer and he has urinary retention too. What is the reason? The reason is that they are having an metastasis, spinal metastasis or epidural metastasis is the reason. Because of the metastasis, the sacral outflow or the parasympathetic outflow to the bladder is disrupted, and he is presenting with retention. So this is how that knowledge will be tested. With this, we have covered one of the most confusing topics, that is incontinences. Thank you for being with me all this while.